Today I'm going to talk once again about healthy longevity medicine and how we are trying to restore the biological age towards the optimal individual performance, or how we are trying to bring longevity medicine also into the sick care setting, where we are hoping that the longevity medicine, diagnostics and interventional arms will kind of metastasize and influence the sick care. So I will really briefly talk about the healthy longevity medicine definitions and how it actually changed from last year, or what's been new in that sense. Then I will move a little bit towards public sector, so healthy longevity medicine entering the academic and hospitals, university hospitals. Then brief overview of healthy longevity tools, so what we're actually already able to apply for the patients, and then give a little bit of an outlook on the crossroads between longevity medicine and oncology and then cardiology, what is actually being now already effectually done in the public sector in departments of the so-called sick care. Then I would like to talk a little bit also about the brain longevity, as we just heard very correctly. So mental health, behavioral health, neuropsychiatry, and longevity, those areas are now permeate each other, luckily, because brain health is a great part of longevity medicine. And then at the end, I would like to talk also about longevity physicians and also refer to some of the questions, even here in the audience, from young medical doctors who are entering the field, which we are very happy about. So again, I'm always opening with this slide, and I probably always will until it will change, hopefully never. Healthy longevity medicine is a field that is always outrunning us and outliving us. It's so powerfully fast and rapid with all the implementations of AI and biotech and other innovations that, especially us as physicians, clinicians like myself, we always have to run double as fast just to be able to actually move this field forward. And as you might appreciate, we have to learn a lot as physicians already in our sick care setting, and then also to acquire all the knowledge in longevity medicine, which requires at least a basic knowledge of AI, machine learning, and also to follow the industry and scientific advancements is quite a bit of work, but a beautiful one. And in January 2020, we were trying to give a very brief idea of what could be the definition of longevity medicine. At that time, it was actually based or inspired by a talk of Dr. Kai Fu Lee at ARDD conference, and then Nature Aging inquired to put it as an article, and we came up with the definition: longevity medicine being a branch of precision medicine that is specifically focusing on promoting the health span and lifespan and is powered by AI technology. And I think it's still partially correct, but it definitely has evolved. And I'm very grateful to be the co-founder and the vice president of Healthy Longevity Medicine. The president, Andrea Meyer, is also here with us today. And in a session, the first physical session of the executive committee, we came up with the definition of healthy longevity medicine being a medicine branch that is focusing on optimizing health span by targeting age-related processes along the lifespan, which is basically saying the same, but in a more in a broader way. So it's really about optimizing the health span, and it is targeting the entire lifespan. So exactly yesterday we just had a very interesting discussion about what is the population, what are the chronological age ranges, or which are the groups that can be targeted by healthy longevity medicine. And it's really pretty much all the groups along the entire lifespan, with very, very few exclusions, such as those with fatal or palliative care. And Healthy Longevity Medicine Society has been established exactly on the 8th of 8th, 2022. So we are just a year old, but already have almost 200 members, medical doctors, which is, I think, a great success, because exactly clinicians are those at the end of the food chain who are going to close the loop from the basic science with the collaborations of the industry, with also AI and computational science, and finally bring it to the patient. So that's actually also the executive committee. And what I would like to point out is that we have here experts from different types of areas that are included in healthy longevity medicine, which is research on stem cells from Professor Thomas Rando, senolytics, and also oncology from Professor Kirkland, Nir Barzilai, metformin, TAME. Professor Harold Pincus, the head of Columbia's psychiatry department, so really targeting mental health and psychiatry in longevity medicine approaches. And another point that is worth mentioning, which I can disclose only partially at this moment, is that we are also working collaboratively with the 3 centers that are opening longevity, I would say, departments or longevity centers within the public sector, university hospitals, which is the Mayo Clinic, and NUS, Singapore Alexandra Hospital, and Sheba Medical Center in Tel Aviv, or in Israel, Tel HaShomer. And I would like to talk about this one because I will be involved in this center. So Sheba is one of the top 10 hospitals ranked by Newsweek for the past 5+ years. And it will be really the first longevity department in the country, and actually also the first longevity center there. It will be fully public, so it will be for free. And all the patients who will be part of that department will undergo the full assessment and will be a part of a research cohort. So that is pretty much the trade here. And Sheba Longevity also has a yearly or annual clinical conference. This year we had it in May, and we were featured in Forbes mostly because we had a little bit of a siren attack of the bombs. So we had a little bit of a gathering in the shelter. But other than that, what is important is that the entire assessment and diagnostic circle will be available there. And we will be also focusing on the mental and cognition, trying to get as many biological clocks as possible. As you might appreciate, it's a little bit difficult in a public setting because of the data exchange limitations, but we'll definitely target those. And then guide the people also with help of data and with help of an app to modify at least their longevity targeted lifestyle interventions and also supplements, etc. And also in this cohort, we'll try to be as close as possible to a twin, to really form a digital twin of those patients with the multi-omics technologies, and also so really going from the omics through the functional data, biological data, and also environmental public health sector data. At the beginning, we will focus also on improvements, especially in the cognitive mental health, sleep, sarcopenia, frailty, and last but not least, menopause and andropause. That was especially important for me to also target the moment for the male health called andropause in that cohort. And as you can see here, we will have specialists working with us. So the idea here is also to really have the center not as a separate part of the hospital, but also to work together with our colleagues from the sick care so that they can learn more and we can learn more from them. I think longevity medicine is still very heavily fueled by the sick care. This is where we learn what we have to target and where we can fight the results of aging or aging-related processes from. So we'll have endocrinologists and rehabilitation center, orthopedic doctors, etc., working with us, and also implementing the longevity diagnostics in their settings. And last but not least, something that is very close to my heart for those who know me, education is a very important part. We would like to bring longevity medicine into the medical schools, into the university. So as Sheba is a university hospital of Tel Aviv University, so we will have actually the chance to bring longevity medicine into the medical curriculum for their studies, but also to train residents and fellows in the department. just a brief mention, longevity medicine is actually expanding pretty much globally everywhere, which is a great thing, and I guess the task for us is really to collaborate and coordinate. This is just an example from the Philippines, where the approach is to start with a small center that is at the beginning in a private hands, but directly already collaborating with university hospital, and then to bring also there the longevity medicine into the medical curricula and into the public health for the entire country. So this is an example from House of Gaia that has been not even yet open physically, but already has a lot of patients and is guiding them daily this way. So as we are developing and bringing our collaboration of AI in medicine and learning from our patients, from the data, and also training the physicians, and looking at the once again, the scale, the chronological scale of what has been going on in the AI-driven revolution, almost, of longevity medicine, where around the year of 2015, we had really the major accelerator coming with the AI, with the technologies of machine learning, deep learning, transfer learning, and federal learning, and others, where we were able to implement those technologies and those solutions to bring data into a context in medicine. Meaning we had many data banks, we had different longitudinal data sets that give us a lot of insights, but they were, without AI, they didn't bring us that many answers to our questions in terms of, for example, bringing the right individual medicine to a person, or calculating the biological age of a person. So 2015 was this moment, and from that moment on, we had really an AI-enforced individual's medicine, where we could use heterogeneous data and bring them into a context. But also what happened already there was what we are using now, pretty much almost all of us every day, the generative AI. So I guess with ChatGPT, it became really something that everybody at least knows about, if not using and implementing into every day. But that was already something that was used in longevity medicine to bring up some of the clocks, some of the biological aging clocks, but also other algorithms. We call them objective functions. So really question that we can ask at that time black box. So generative AI gave us a lot of open doors in medicine. Now with ChatGPT, more questions have been asked and more caution has been also alerted for. There's a very nice article in Nature Medicine that is bringing this to a subject and really showing off what are the red flags for clinicians and what are the extremely green flags. So where can we really enhance our rational diagnostics, our bringing the empathy into the generative AI-based algorithm, and how together we can help our patients in that sense. And so really, longevity medicine is something that is not replacing the sick care. I think the reactive care, the sick care, the treating diseases, that will always be necessary. And also, longevity medicine is not the typical prevention medicine as we know it, the primary prevention, secondary, tertiary prevention. It's an area of medicine that has been there for a long time, and it's still extremely valid. It's the detection of early signs of diseases. But really, longevity medicine is targeting something above it or something before it. You can name it. It's really about detecting the risks of developing diseases, and most of those diseases are age-related. Not all of them, but most of them. And so when we look at the patient journey, not to repeat myself too much from last year, but I guess this is very important to remember as we are looking at the patient journey, at the life journey of a person. We are mostly still in our setting looking at the chronological, so the x-axis, the chronological age, the years based on your date of birth in your passport. And we are correlating this to performance. Again, performance meaning the physiological, functional, cognitive performance. We are usually reaching a peak that is very short, and after that there is a decline. And this decline, of course, can be accelerated. We are now able to measure it, at least partially, by biological age measurements, the speed of biological age. And as we are aging, of course, we are accumulating comorbidities, we are multimorbid, and then at the end of life, usually at a very dysfunctional state, sometimes even palliative. But the point here is, as a clinician, we are usually bound to normative values that are based on normal values, the minimal standard, as we heard yesterday also in one of our clinical brain sessions. This is what we are looking at, and you all know those normative forms, normal, not normal, within the range. This is something that we have been taught in the sick care to base our judgment and base our therapies on. Meanwhile, what we can do now much better, and of course we need more data and we need more time to get to a perfect state or a much better state than right now, but at least the approach, the individual approach, by not only looking at the chronological age, but actually at the biological age of a patient, of a specific patient at a specific point of time, so really try three-dimensionally, 3D, and also to know what would be the optimal biological age of that patient at that specific point of time, and then implement measurements to bring that patient to that optimal age. So no, not always it will be reasonable to bring somebody from 80 to 20. That's actually also not logic, but there are optimal ages and optimal biological frames that will allow that person to perform optimally at this biological point. We are talking about closing the gap of lifespan and health span. You will hear that very often here. It's really about the gap between the years lived and the years lived in good health. And now there is also a debate, what is health, what means good health, but we know in general that it means reasonable performance done by somebody. And to get that, we need, of course, collaboration, not only between medicine and science, as we see here, including industry, science, but also society and public health. So that is something that is also increasingly growing in attention and also in efforts to bring those hallmarks of aging, biomarkers of aging, and in general, longevity medicine approaches into the bigger picture, into the public health sector, and also insurances. And in simple terms, it really means to bring or also to shift the proportion of people being at the point of worse health, or already being there at where they are really just following the lifespan path, to those who are on the health span path, and then we are trying also to extend that health span. And how do we do it? We have diagnostic part and we have intervention part, and many people, I mean, almost always I get the same question: why are we doing all these diagnostics if we still don't have, let's say, FDA-approved clinical trials, evidence-based interventions in longevity medicine? And the answer is here, I guess, really to get better data in order to have objective measurements for those longevity interventions that will come hopefully soon into the reality in clinical settings. So in terms of longevity diagnostics, we always try to get as many data as possible, and there are now really great settings, and a lot of those settings, including private clinics, now also entering this public sector, where we can not only get a lot of data, again, heterogeneous in a mesh, but in a standardized way, in a way that we can then collaboratively use it in order to develop recommendations and guidelines. That also includes not only data from biological functional measurements, imaging, MRI, environmental measurements, but also pharmacogenomics, polygenic risk score, as you can see here, and other ways for us to really bring individual medicine into the point. And I guess something that most of us already use, and it's really great that those measurements are also now really being implemented into the large public health and large public hospital settings, are the monitoring devices, or the monitoring ways and means to get more data, to get continuous data, to get data that will follow not only those who are sick, right, but also those who are healthy. And then also with those two cohorts, we can actually extract and shift with the federal learning, let's say the curve, and then get more biological aging clocks, more precise biological aging clocks, and also organ-related biological aging clocks. So CGMs, liquid biopsies, digital pathologies, sleeping testing, and like mini polysomnography, and many more are now applicable, because we know that aging is not consistent. It's not consistent in all the in different types of organs and in different types of tissues and even on different cells, right? So in order for us to really get to the point of maximal individualized healthy longevity medicine, we need to have better measurements for all those levels. And then also to clinically transfer them into what we can observe, right? So it's great if we can measure the biological age speed of a specific cell or tissue, but then how do we also see it clinically in a patient? How can we trace that? Because the decline on different levels is different. And how then can we apply a better longevity protocol, right? So really make it in a granular way, not only in terms of time and lifespan, but really also in terms of which of those diagnostics might be valuable and which ones might not be that valuable at a specific point of time. So some of the diagnostics will still load you with some of the radiation and so on. So it's also very important to have here longevity physicians working on it. And biological age measurements right now are possible with different aging clocks. I really love the slide of Joanna that is really comprehensively showing those different measurements that they are capturing, and many other clinics do so as well. But where we are trying to get here, and you can see on this picture, is really to have more and more organ-based biological age measurements, because we know that not only the general, the comprehensive, the entity of a biological age is important, but really the organ-specific one. And we have, a variety also of deep biological aging clocks, meaning those that have been developed based on AI and generative approach. And also those are targeting different types of data, some from pictures, from the skin, but also microbiome aging clock, of course, a variety of epigenetic aging clocks, methylation ones, heart aging clocks, HRV and ECG-based clocks, behavioral aging clocks, subjective, so psychological aging clocks, and of course, something that I really like a lot is the deep hematological aging clocks, so based on blood values. And I think many more are coming, and as you can see here, they're still very much varying in the MAE with the deviation that they have and with their specificity, as to say, for the biological age and prediction rate. But still, you know, this is an area that is really developing well, and it's really helpful to have those metrics. Even in the clinical practice, we take blood from almost everyone, right? So just to use that, those values to calculate the biological age is not exactly very difficult, and then the algorithm can also tell you which of the parameters could be optimized. Again, it's not the same like the normative values that we have from normal, not normal, but something that is really targeting the optimization. And then you can track the patient along the lifespan. So here you can actually see a patient that was trying to self-experiment and took a lot of supplements. So he started at 38, but then within a year he grew to 44 in the biological age. He took a bit too much and not exactly very much guided. Yeah, he was not guided by anyone. Did not listen to advice to stop it, so he grew in half a year, then again by another biological age. But now he is under guidance, and he reversed his biological age again with a comprehensive plan, with a comprehensive guidance, and with a lot of discussions and adjustment. And what I want to mention here is also it's important to have a guiding physician because there will be life events. There will be life events such as disease, such as COVID, such as pregnancy, and that will impact the longevity plan. And that is important that we have the means to track it. Here you can actually see positive development of a patient. You don't see a huge reversal of the biological age, but you can see that the biological age stayed stable along increasing chronological age. And that is also a very good success, especially for those people. And just a few minutes on really bridging the sick care and longevity medicine. So many people ask me, what are you doing? And I'm a clinician 100% in a clinic. I work in medical oncology department, very closely also with ICU, very much terminal patient. Right now working with pancreatic cancer. So for those who know, it's pretty much the most trist one. But at the same time, I'm working with longevity patients and those who are really at the spectrum of healthy people, where we are just trying to optimize. And what is the bridge here? And the bridge here is, for example, something that is now popularized in media. So this is a Harvard Gazette article that was very popular, that was showing or thematizing the point that with specific diseases, the biological age is growing and then reversing after the person restored the health, such as COVID. But it also mentioned pregnancy, and many people are coming then and want to be longevity patients because they are planning to be pregnant, or they are pregnant, they heard that, and they want to know their biological age. And so also during the COVID time, we did a study with New York cohort, 5,000 plus patients, where we measured their biological age and correlated it to mortality and complication rate, and the same also with chronological age. And we've actually been able to show that calculating biological age was predictive for worse outcomes, and the same was true for chronological age, but much less statistically significant. And when we were looking at determining just single parameters, so some of the people are still measuring just 1 or 2 or 5 or 6 parameters, for example, from blood. Again, that was also not maximally predictive. So really calculating biological age was much better as a predictor, as you can see here, also a predictor for, so reverse predictor, those who actually had more comorbidities that we didn't know of, but we saw an accelerated aging and a higher biological age. Those people also had a higher complication rate. We did another study in cardiology. This picture is actually from a big paper on biomarker consortium from China that came out a few months ago. And in a cohort in Italy, it's the largest cohort on heart failure and chronic heart failure patients, we have seen that also there, the prediction of biological age was correlated not only with the outcome, so not only predictive value, a higher mortality, but also, and you can see here the distribution, so a lot of those patients that are here marked in red, they were predicted older biologically than they actually were, and it was actually then correlated to higher rate of complications within the chronic heart failure. So stable chronic disease, but still worse outcomes in those who have been biologically older. And that was then shown being statistically significant when adjusted to the cohort. Another important part, and something that I'm working on, is geroncology. So as we all know, cancer is bad. Cancer is something that is probably one of the best developing disciplines with novel interventions and novel therapies, but we still have the same problem for the past 12 years. We still do not know how to manage the older patients in oncology. So geroncology is a very important field that is now also a part of many of oncological societies, but we still don't know how to really best treat those oncological patients that are not at the extremes, that are not extremely super fit or extremely frail. For those, we actually know what to do, more or less. But for those in between, we don't know how to triage and stratify them. Meanwhile, age is the #1 risk factor for cancer. out of all, and also a #1 predictor for higher mortality based on cancer. So it's not a surprise that we see more cancer because the society is aging, as you know. And also at the same time, oncology and longevity medicine are the two disciplines that have the most intersections. So the pathways and processes are very much overlapping on many levels, such as mTOR, rapamycin, and many others. So again, this is another part. So many of the interventions for cancer most probably will also be, in one way or the other, working in longevity medicine. So now there's quite a big movement in senolytics that are being developed that will be applied also in oncology. And probably, so there's a big hope in this sector, especially for those cancers that are very difficult to treat, such as triple-negative breast cancer. And again, we very often do not know how to treat the oldest old cancer patients. And when we say oldest old cancer patients, we are referring to chronological age, because as you know, those patients are not included in randomized clinical trials. But we will more and more look also at the biological age. And for those patients, the question is, what is more important, the quantity of life or the quality of life? And how can we predict the quality of life for those patients? So what is helpful here is, of course, the geriatric assessment. It's great, but again, it also doesn't reflect everything. So what we have done now is we looked at several cohorts. For example, here are cohorts from Switzerland, so relatively small, but quite representable across different cancer settings of solid cancers, so not hematological cancers. And we have seen here that biological age prediction, so that's biological age, is strongly related also to the prognosis along all the different kinds of cancer, meaning translated into the clinical setting, probably a biological age prediction will be helping us in the triage in terms of deciding how much and which treatment will be given to those patients, and also at the same time, what will be their susceptibility to toxicity, which then will very severely impact their quality of life. And we have seen that biological age prediction is much more helpful than targeting, again, just one parameter, such as albumin or LDH. Few moments on cerebral health, really the last slides. Cerebral health and neuropsychiatry are very important. How do we measure that? That's actually a big challenge. We have good methods right now, or much better methods with NLP and also with computational psychiatry. So for those of you who are interested, really motivating you to look at, for example, Hallmask or those papers here. There are also new frontiers in brain biomarkers in the blood that are being studied at the University of Chicago and others. So that is also something that can be easily implemented into the clinical setting. And last but not least, of course, quantification of the brain imaging. So we were talking about how do we use those data also for our clinical settings. This is an example of brain age where the quantification of different areas of brain are being measured and then related to the brain age, that is also correlated to the health span. Actually, that is the only biological clock that I score worse. So I'm older biologically because a lack of sleep. Okay, not advertising that. Yeah, and as you can see here, it's also correlated to worse outcomes. And last but not least, for all the young doctors here in the audience and for everybody who is interested, longevity physicians, healthy longevity physicians, we need a good education, we need good curricula for those young doctors who are entering the field, and also those doctors who have been in the field for many years and want to enter the field. Therefore, we have different programs that are already developed. For those who still don't know, this one, for example, it's longevity.degree, and it is allowing doctors to get certified CME, certified in longevity medicine. It's been developed into many countries, so now it's also available in Indonesia, also in China, in Portugal, in Spain, and you know, all around 5,000 plus doctors have taken it in more than 100 countries. But in general, the doctors are asking, how do we enter the longevity ecosystem? And I guess this is exactly the way. Try to engage into the conferences like this one. Try to learn and educate yourself on those curricula. And at the end of the day, try as much as possible to implement longevity medicine, diagnostics, and then interventions into your current clinical practice. Thank you so much